Okay. I'm assuming that the sound works. Look how stupid if it doesn't later. Little microphone is lighting up. So hopefully it'll work. All right. We'll review for this exam. I realized that the change in format was sort of last minute, is not super helpful. But apparently I don't have the software necessary to make live streaming on YouTube work. I guess I should have looked into that. But I figured, look at all the idiots who do this on YouTube. Surely it's ridiculously easy. The lesson there, do your research. Anyway, so I guess I'm not sure if anybody can hear me. Let's go with yes. All right, so ideally, this will work. Although I'm still not 100% on the format. So just like the last exam, you'll have 50 questions. This one will cover excellent. All right, so lymphatics, immunity, and then all the cardiovascular stuff. Which is really what we've covered. So important stuff here. Like the other exams, it's focused on big picture stuff. I'm going to start by answering a question that I got in email just the other day about how antibodies and all right, I was saying I'm going to start by answering a question I got in email the other day about antibodies and how antivenoms work. So, like I said, when they make antivenoms for anything, whether it's rattlesnakes or spiders or whatever, it works by taking small amounts of that venom and injecting it into an animal. Not so much that it kills it, obviously, because that's not helpful, but enough where there's an effect. You wait for the animal to get somewhat better, and then you do it again, and you do this repeatedly. In the process, the animal is going to build up antibodies against that toxin. We did talk about antibodies, and some of these different antibodies you should be aware of. So, immunoglobulin M, this is the first one there. This is primary response. That's not really what we're going for here. What we're looking for is immunoglobulin G. This is your main antibody. And this is what we would see in the secondary response. So this is immunoglobulin G here is what you form after you've been exposed to something. This is what we would think of as immunity. And when we're doing this whole thing with like rattlesnakes or whatever, you're creating those antibodies in animal, and then you're using them to treat people. And the question I got in my email was, why doesn't your body reject that? Well, when we talk about rejection, normally what we're talking about is an organ transplant, which would involve actual tissues and cells. Well, what we're
And I had a Zoom
transplanting
in.
here is serum. There's no cells involved. It's the extracellular part of blood from this animal. Now, with that, there are some risks to this because people do have allergies to animals, and there is the risk of allergic reaction with these antivenom. In the United States, we have an antivenom for black widow bites. And if you've ever been bitten by a black widow, it freaking hurts for a while, and you wish that they would do something. Most often, they won't do anything for you other than give you a painkiller, because you're much more likely to die from anaphylaxis from the antivenom than you are from the spider bite itself. The treatment's more dangerous than the spider bite, although the treatment does make it stop hurting, assuming you're not allergic to it. So yeah, there are examples of that where people have allergic reactions. That's not rejecting it; it's just that allergic response that's happening there. As long as we're sitting here talking about antibodies and that allergic response, you should remember that immunoglobulin E is the one that's really responsible for that allergic reaction. It causes histamine release. Another antibody we talked about is immunoglobulin A. Immunoglobulin A is in mucus. And right now, immunoglobulin A is not super important, although like future immunoglobulin A has some potential because there are some companies that are working on vaccines that create immunoglobulin A type antibodies that would be in the mucus or the saliva. So it would be protecting you from actual entry of the virus rather than treating it once it's in you. So anyway, this is a question I got about how the antivenom thing works. For rattlesnakes, it's kind of a weird deal. Rattlesnake antivenom is widely available, but in the United States, rattlesnake venom is also ridiculously expensive, and it's like $100 if you go to Canada or Mexico. But in the United States, it could cost you $100,000 to get treated for rattlesnake bite. So yeah, there are cases of people dying because they didn't want to pay for it, which is probably worth it in hindsight, but they're super dead. All right. So like I said, for this exam especially, we're really focused on big picture physiological things. So let's back up a bit. All right. So one of our main, okay, so I guess I should start there. So lymphatics, immunity, cardiovascular stuff. What you guys need to be focused on in terms of like lymphatics is the principle of lymphatics as this drainage system. I'm not worried about like lymphatic anatomy or the anatomy of a lymph node or any of this stuff. Just the big picture idea that the job of the lymphatics is to drain that excess interstitial fluid. So the fluid in between the cells. That's the whole job for lymphatics, just to drain that excess fluid, and of course to filter it and everything as it goes through, and provide sort of the structural support for your immune system. But the big job here is that drainage. A term that we use a lot here in terms of interstitial fluid is edema. Edema is the accumulation of interstitial fluid. And it's not uncommon to see peripheral edema, especially in older people, in pregnant women. Even if you have an injury and there's some swelling there, that's edema as well, where the fluid builds up outside the cells and that area swells up. But it's the lymphatic's job to drain that excess fluid. And if you ever have like a blockage of a lymphatic or something, you'll see that fluid build up outside the cells and there'll be a lot of swelling of that area. You'll see that peripheral. We also use edema, refer to things like pulmonary edema or cerebral edema, and that would be the buildup of fluid outside the lungs or the brain. Both of those would be really bad, actually. But in terms of lymphatic, that's really all you need to be focused on. There aren't any in-depth questions about lymph nodes or lymphatics or like how lymph nodes work or yeah, I'm not just really concerned about that other than this idea that it's draining. The immune system a little bit more in depth, but with the immune system, really your concern should be first the difference between innate or non-specific immunity and the specific immunity. So non-specific versus specific immunity. That's a big deal. You can hear my louder child screaming in the background. All right. So innate immunity, like the skin, the mucous membranes, stuff like that. Hold on. All right. Specific immunity. This is really what we think of as immunity. And we have our B cells and our T cells. Now here with B cells and T cells, you need to associate B cells with moral immunity and T cells with cell-mediated immunity. I'm not worried about clonal selection or any of this process with either B cells or T cells. The difference between the two is, according to humoral immunity, is antibody mediated. This would be for something that's extracellular. And T cell cell-mediated immunity is intracellular. So antibodies are dealing with stuff that's not already inside your cells. So a toxin or an infection or something, but it's not yet inside your cells. Once your cells are infected, well, now we're looking at T cells. So that's something to keep in mind, is that T cells are killing your cells, but the abnormal ones, the ones that are infected or the ones that are cancer or whatever, they're just not right. Now it's not that widespread. It's very specific. They have to learn the antigen they're looking for, but they are looking for your cells. Non-specific innate immunity. One of the cells we talked about are those natural killer cells. Natural killer cells are very much the same in that they're looking for abnormal cells. The difference is that natural killer cells are not specific, where you have T cells that are looking for, say, cells of your body that are infected with the measles virus. Natural killer cells, it doesn't matter what it's infected with. It's not looking for just that one thing. If you have cytotoxic T cells that are out there hunting measles infected cells, and it comes across a cell that's infected with another virus, that's not its job. Keep going. Natural killer cells will kill whatever, as long as it's not right. So they're non-specific immunity or innate immunity. Specific immunity, the cells have to be exposed to something, they learn it, and then they have that one specific target. So this one thing that we did spend some time talking about here is the idea of a vaccine. The idea here is to spare the response or the primary response period. Incidentally, if you go to the vet, you can have your dog vaccinated for rattlesnake bite. And what they're doing is they're injecting your dog with parts of the rattlesnake, not rattlesnake venom totally. Obviously, you don't want to inject your dog with rattlesnake venom unless you super hate your dog, and then okay. But they're injecting it with parts of it so that the dog's immune system has some awareness of that, and then if it gets bitten by a rattlesnake, it's already got the antibodies in play to bind to that venom. And that's not something practical to do with people, because really, how many of us actually get bitten by a rattlesnake? Right? It's not something that comes up a lot. That's why we don't vaccinate everyone for anthrax. It really doesn't come up that much. So just practicality, it's easier to treat that afterwards. I don't believe there's like a human rattlesnake vaccine, and I don't recommend trying the dog one. So with this, one thing to keep in mind here is the idea of a determinant. Determinant is the part of an antigen that really binds to, in this case, antibodies, but let's look at that, the antibody or whatever, the part that actually evokes the immune response. It's the part that's recognized. There's a slide in your PowerPoint thing that's got like a big round antigen with like little puzzle pieces off to the side. And the little puzzle piece is just the part that's recognized. Your immune system doesn't recognize the big picture. It recognizes tiny features of that. So when they vaccinate you, for instance, for like, oh, measles or whatever, they're not injecting you with measles. They're injecting you with broken pieces of that so that your immune system can learn those little pieces. It's not infectious. You're not going to get measles from the vaccine. You're not going to get flu from the flu vaccine, etc. But they're injecting with the little chunks of it. So then when you actually encounter the real one, you already have that that immune memory in place so that you can release that secondary response, which is a lot more powerful, a lot faster, and you don't actually go through that primary response period and get sick. So a lot of the questions that come up here with the idea of vaccinations is, and I've been here, right? You go get the flu vaccine and you feel like crap. You get a fever, it feels awful for like a day. That's non-specific immunity. A fever is non-specific. Feeling like crap, all of that, that's non-specific because you did get an injection of a foreign molecule and your body responds the way it should. It's not mounting a full-blown immune response to it. You're not actually getting sick, although you might feel that way. You didn't actually get an infection, and that usually doesn't last very long. The other question I often get here is, I got my flu shot, and then I immediately got the flu. Well, there is a window there, right? You get that vaccine, and the vaccine triggers the primary response period, which is like a week. If between those two, if between you getting the flu and you getting the shot, if you didn't have enough time, you may still get the flu, or you may have already had the flu when you went there because it's got an incubation period. Or you may have gotten a vaccine for a strain of the flu that you didn't get and you got a different strain. That sucks, actually. But for the most part, vaccines have been really reliable. And still, there's a lot of stuff like injecting you with diseases or whatever. I had one semester where I had a student that was convinced that it was like government mind control because they've got nothing better to do. Mess with that one girl in Leveland. So yeah, we've made lots of progress with vaccines and a really good job of eliminating things. And hopefully we'll have some sort of vaccination program in place for our current viral pandemic thing soon, so we can all go back to being normal. All right. But big picture for immunity, this, again, big picture idea. I'm not going to ask you about clonal selection or like major histocompatibility complexes and CD4 versus CD8 T cells. That's really not what we're looking for here. That degree of detail is something for a semester-long class in immunology, or really, it might even be more appropriate for microbiology. But at the moment, we're just touching on this. So the bulk of your exam then is with the cardiovascular system. And there are some really big picture ideas that are going to be important to you clinically, and one of those is the maintenance of blood pressure. All right. So the reason that blood pressure is important is because blood flows with a pressure gradient. It moves from high to low pressure. So pressure is highest at the aorta as it comes up the heart, and it's pretty much nothing at the vena cava when it drops back in. So blood's always going to move in that direction, from the arteries out and back into the veins, because that's high to low pressure. And the maintenance of that pressure gradient is what makes circulation work. And without that gradient, you don't have any circulation. Blood's not moving, which is obviously bad. So quite a bit of stuff going in here to blood pressure. Factors that change blood pressure and blood flow in ways that we manipulate this pharmaceutically. Because high blood pressure, hypertension, is quite possibly the leading cause of people having a heart attack. Today, we think that blood pressure is more of a causative factor than even cholesterol in terms of your development of cardiovascular disease. And right, heart disease kills more people than anything else. So we worry about blood pressure. In the United States, hypertension, high blood pressure, the most common primary diagnosis of anything. And even with that, the vast majority of people that have hypertension don't even know they have it because there really aren't any symptoms until the whole massive heart attack thing or a stroke or whatever. So when we talk about blood pressure, a lot of times we talk about blood pressure in light of treating this. And there are different ways we can do this. All right. So things that influence blood pressure. One is volume. Volume is directly proportional to pressure, which means that if we increase blood volume, increase blood pressure. Okay. The next thing that's directly proportional to blood pressure is cardiac output. Again, directly proportional to blood pressure. You increase cardiac output, which is the amount of blood your heart's pumping out, you're going to increase blood pressure. Other thing here is peripheral resistance, or just resistance. And if you increase resistance, you increase blood pressure. So now we can manipulate these things. So we have medications that are antihypertensive. And it's really your frontline, easy to use antihypertensive is a diuretic. Because what a diuretic does is it decreases volume. Right? You're constantly having to pee, and urine is coming from the filtration of the blood. So you're losing fluid constantly. So you're going to lower your blood pressure. We decrease the volume, we decrease the pressure. So that's really the simple end of this, is just manipulating that. Then we get into this idea of resistance and cardiac output. Now, peripheral resistance is the difficult thing. If your blood vessels constrict, your blood pressure goes up. But if your blood vessels dilate, your blood pressure falls too much. So we don't usually use like a widespread vasodilator to treat hypertension. We may prevent constriction. We don't necessarily want to cause dilation. More on that in just a second. First, let's look at this idea of cardiac output. And to do that, we first need to look at the factors that contribute to cardiac output. All right, so cardiac output. Cardiac output is heart rate times stroke volume. Stroke volume is the end diastolic volume minus the end systolic volume. So translation there, cardiac output, beats per minute times volume per beat. And then your stroke volume is how much blood went in minus how much blood is left over. And that tells you how much blood went out. And we talked about factors that influence stroke volume by changing the end diastolic volume or the end systolic volume. We have preload, contractility, and afterload. Preload is really sort of how much blood went in, because the more blood you put into the heart, the more it stretches the heart out. And if you stretch out the heart, it contracts harder. That's preload. So more blood in, more blood out. Contractility is the force of the heart, regardless of the volume, how hard your heart beats. And that's controlled chemically. Things that affect contractility are called inotropic agents, or inotropes. And so a positive inotrope makes your heart beat with more force, and a negative inotrope makes your heart beat with less force. And then afterload is the force working against your heart. And as we're talking about hypertension, if we increase your blood pressure, that increases the afterload. Because now there's more force pushing back on the blood, so it's harder for the heart to get blood out, which then explains the symptoms we see in somebody that has high blood pressure. People that have high blood pressure, the wall of that left ventricle gets thicker and thicker and thicker, having to work so hard to push blood out. All right, so back to this idea of medications to treat high blood pressure. The diuretic, that one's really simple, just decreasing volume. Another thing that we use here is called, it's called a calcium channel blocker. That calcium influx, the calcium moving into the cardiac muscle cell, makes it beat with more force. And if we block that channel, a calcium channel blocker is a negative inotropic agent, which means it makes the heart beat with less force. If the heart beats with less force, we decrease cardiac output and lowers your blood pressure. Calcium channel blockers. Ask your doctor about prescription Norvasc. That's sort of the go-to calcium channel blocker. Beyond all of this, though, we have some hormonal control here that is, again, manipulated easily with pharmaceuticals. And we have a hormone here that's really made to raise your blood pressure, and that is angiotensin 2. Now, angiotensin 2 does several things. It's a vasoconstrictor. Because it's a vasoconstrictor, that means it's doing this. It's increasing resistance. It's constricting those blood vessels. Resistance is going up, so blood pressure is going up. Blood pressure that way. Angiotensin 2 also causes aldosterone release. And aldosterone causes you to retain sodium. If you retain sodium, you retain water. If you retain water, you also increase volume. So this is a really potent hormone. We can block that because of the way that angiotensin 2 is formed. We use a medication called an ACE inhibitor. And the ACE inhibitor blocks that enzyme, the angiotensin converting enzyme that ends up creating angiotensin 2. And then in that way, we can prevent that action of angiotensin 2. So we prevent that hormone from raising your blood pressure. This is prescription lisinopril. Is one of the the more widespread ACE inhibitors. Now, the other thing we could do to treat high blood pressure is to reduce cardiac output. And one way to reduce cardiac output is to prevent your heart from beating so hard and so fast. And we can do that using a beta blocker. A beta blocker blocks the beta-1 adrenergic receptor on the cardiac muscle. Your heart can't beat so fast. Adrenaline doesn't make your heart beat so fast and so hard, is what it amounts to. And that reduces cardiac output, which reduces your blood pressure. So there are multiple pathways we can use here to treat hypertension, but it is a big deal in terms of well, most Americans anyway, this whole treatment of hypertension. Antihypertensives are probably the most widely prescribed medications. So that maintenance of blood pressure idea and that whole, the factors that go in the cardiac output, that's a big picture concept. Of course, the other things are important too, like the difference between veins and arteries. Remember that arteries, of course, carrying blood away from the heart. These are high pressure, low volume, and the veins, high volume, low pressure. That's important, the difference between arteries and veins. The different types of capillaries, you should know what the different types of capillaries are, like the fenestrated, sinusoidal, continuous capillaries. Know what those are. I'm not going to ask any questions about like cardiac action potential. That's something we covered in AMP1. You will need to, oh, that's a good one. You will need to be able to label the parts of a normal EKG, not multiple leads or anything, just the one thing where we have a so things that you need to be able to label here. You have the P wave. QRS complex. And the T wave. The P wave, in essence, is the activity of the SA node, atrial depolarization. Now, right here, in between the P wave and that QRS complex is that sort of flat line, and this is your delay at the AV node. Right, the fibers of the atrioventricular node are smaller. There's fewer gap junctions there. So you get about 1/10 of a second delay, which you need so that you have time for the atria to contract and blood to move before the ventricles contract. The QRS complex, this is ventricular depolarization. So this is the activity in the ventricles in QRS. And then the T wave is those ventricles resetting. You need to be able to label that. I'm not going to ask you to recognize like a junctional rhythm or a heart block or anything like that. I'm not going to ask you to diagnose anyone based on their EKG. But you should be able to label the parts of the normal EKG. And you should be able to associate them with sort of what they mean. Right. Let's see. The pathway of blood through the heart is a big picture concept. And often when I talk to people at the nursing school, I'm like, what do you need people to know? This is one of the things that they emphasize with us, is that one of their concerns is that idea of big picture stuff and not getting lost in minutia. And the example that they always say is the pathway of blood through the heart. They would much rather you know the pathway of blood through the heart than they would like the parts of the cardiac action potential. This is important. So you need to be able to trace the pathway of blood through the heart, and we'll do that here. All right. So we're going to start in the right atrium, because that's convention. So we're here in the right atrium. Now, I'm blue because, right, this is low oxygen blood. Blood's going to go from the right atrium down into the right ventricle. Now, to do this, it's going to pass through that tricuspid valve. And we're in the right ventricle. Now, most of that's just gravity, too. The atria do contract to push blood down, but most of the blood flow from the atria to the ventricle, like 80% of it's passive, it just drops down. The right ventricle, we're going to go up and out pulmonary trunk. To do that, we're going to pass through the pulmonary semilunar valve, the pulmonary trunk, out the pulmonary arteries, which I'm not going to write because I'm running out of room already, to the lungs. Lungs, we're going to pick up oxygen. We're going to come back into the left atrium. Now, to do that, we're coming through pulmonary veins, but again, I'm kind of running out of room, so I'm not going to do that. The left atrium, I'm going to drop into the left ventricle. Here we will be going to the bicuspid valve from the left ventricle, up and out the aorta, and into the aortic semilunar valve, and then out to the body. And we'll lose that oxygen in the body and come back to the right atrium through the vena cava. There's obviously a better drawing of this in your PowerPoint. But this is the general idea here. Cycle of blood through the heart. Another thing that's important here with this cycle of blood through the heart is the difference between adult circulation and fetal circulation. Because the fetus isn't breathing. This whole lung thing that's not helping you. What happens in the fetus is that you pick up oxygen at the placenta. That exchange happens way out at the placenta. And high oxygen blood comes back through those umbilical veins and drains into the right side. So the blood that comes into the fetal heart on the right side is already oxygenated. It doesn't have to go out to the lungs. So the first thing we have is a bypass from the right to the left atrium. This would be your foramen ovale. And the second thing we have is a bypass between that pulmonary trunk and the aorta. The ductus arteriosus. And what that does is that bypasses all of this because it's all high oxygen blood here. Now, you need to know that ductus arteriosus will become the ligamentum arteriosum in the adult, and the foramen ovale becomes the fossa ovalis in the adult heart. And these structures close very quickly after birth. Usually it takes the ductus arteriosus a couple of weeks. The foramen ovale closes faster than that. And so those bypasses close. This allows blood to bypass that pulmonary circulation. Let's see, there's stuff here. Right, veins carry blood back to the heart. For the most part, that's low oxygen blood. reversed in pulmonary circulation. So the veins don't always carry low oxygen blood, but they do always carry blood back to the heart. Arteries don't. Arteries always carry blood away from the heart, but it's not always high oxygen blood because pulmonary circulation is reversed. But arteries carry blood away from the heart. Veins carry blood back to the heart. The exchange happens at the capillary. This will be the first of the lab exams that we have as well. And I use that term really loosely because obviously we're not in a lab and I can't have stuff laid out for you like I normally would. Especially here in the cardiovascular system, we would be leaning really hard on the Anatomage virtual dissection table. It's great. We can dissect those arteries out. We can dissect the heart. We can dissect it while it's still beating. It's really awesome. And we can't do that here. So we're kind of going just with what I happened to hijack from the lab before we left. So there's a video on your YouTube about heart anatomy. That's the Somto heart model. And there's one that's the cerebral arterial circle, the blood vessels in the base of the head. You might see some other blood vessels labeled on diagrams, but that's fairly straightforward. I'm not going to spend a lot of time going back over lab stuff because it's, especially in this format, it's really, really easy. The diagrams, it's either going to be labeling diagrams or photos of the stuff from the video, but you'll see that as a separate exam, if you will, on your exam page. I won't put a time limit on, I won't put a time limit on either one of them. So once it starts at midnight, you'll have until the next day to finish both of them. And I don't expect it to be too much of an issue either way. All right, so with that, questions? If you have questions, I should be able to hear you as long as you're not muted.
Will there be any questions about diseases of the heart or anything?
No, you won't have any pathophys questions like diagnosing stuff. And I'm not going to ask you to like distinguish between like different defects or whatever. If there are any questions about any sort of pathology, most of that would rely on your knowledge of understanding the pathway of blood through the heart. So for instance, like with transposition of the great arteries, if there's any questions there, it will be flipping those two blood vessels, what happens. And you should know that the aorta carries oxygenated blood out to the body. The pulmonary trunk carries low oxygen blood out to the lungs. And if you swap them, you get the opposite effect. So there's not going to be any like diagnosis or any questions about naming diseases or anything like that. Anytime there's any pathophys stuff, it's just going to be understanding the normal physiology and how that applies.
As far as the lab goes, is it just going to be pictures or is it going to be like an interactive kind of lab?
Oh, it's super not interactive. It's just pictures and diagrams. At the moment, that's sort of the best we've got. We're all exploring sort of interactive software, although we really haven't found a great solution for this coming up. So it'll be interesting in the fall at the very least. But at the moment, it's just pictures and diagrams. So the lab, there aren't a whole lot of lab terms, just the ones that are covered there. But even then, Anything that's labeled, you should be able to find really easily in either your text, pretty much any other resource you have access to. So that's kind of the consensus we've had, is that part of this whole online learning thing is going to be exploring your ability to find answers to stuff if you don't know it. Like, and that would be the case there. If there's something labeled and you don't know what it is, you should be able to find it.
Okay.
So yeah, that's, nobody's policing like you Googling stuff or whatever, because obviously in real life you'd just Google that.
Yeah.
Yeah, if you ever wonder why your doctor leaves the room, he's like, I'll be right back. It's so he can go Google that crap. Weird rash. Yeah. Other things. Make sure that go back and review the PowerPoints and the lectures as well. But really, it's fairly straightforward. I don't expect you to have a whole lot of difficulty with it, although there's a lot more physiology going on here than there was with the first exam. I still don't expect it to be that difficult for you. After I get this posted, you'll see PowerPoints come up for the next part, which is renal respiratory acid base. And shortly thereafter, you'll probably see the rest of those PowerPoints, or at least the digestive stuff, come up, if not all of it, so that you have at least those outlines. And then the lectures I'll get pulled up on YouTube so you can access those as well. We're moving really fast here. Thus far, everybody seems to be doing okay. And so far, so good. Any other questions, thoughts? I can't tell if the screaming kids are on my end or yours.
Oh, I don't have any screaming kids.
Crap, that means they're mine.
How many questions are on the lecture part of the exam?
It will be 50.
50? Okay. Your class is proving to be not more relaxed, I don't want to say that, but less demanding than another class that I'm in. I have essays and discussions due every other day.
Okay, so here's my philosophy with this whole online thing. A few semesters ago, so my wife was finishing her degree in fashion design at Tech, and she had missed a seminar class they were making her take, and it was online, and it was like that, like there were essays and discussions and posts, and it was time consuming. When we started this whole pandemic thing and everybody was locked down and at home, all I could think of was when she was doing that, super time consuming. And it's not like you don't have anything else going on. It's one thing when you're in class and you've got that block dedicated to being there and you don't have anything else going on. But when you're at home, there's a lot of other crap going on. And
yes, there is.
When you're at home and you're locked down, or for some of you, when you're not at home because you're at work in a healthcare facility, like you got a lot of other stuff to do. And my philosophy with this was to make it as flexible as possible, so that it wasn't you have to be here at this time and do it at this time, so that it's constant upkeep and time consumption, because there's just way too much going on at the house.
Yes, I completely agree. I basically live in a nursing home. I have 3 patients that me and my mom take care of, and this pandemic has proven a lot more work than I thought it was going to be at home.
That's right. Everybody's like, what are you doing to pass the time? I'm like, who has time?
Yeah, I don't have any time at all. I have a dementia patient, an Alzheimer's patient. My dementia patient also has several types of cancer. He's very, very old. He's 92. And I have a renal patient who is blind. So this hectic life, my mom would stay home and, take care of everything. But now that I'm home and I'm able to help, it's proving to be a lot more difficult than I thought.
It's something, but
It definitely is.
yeah, and that's so hopefully there's enough flexibility here that we can not add any more stress than it has to be and still get the point across.
Yeah.
Because a lot of this will come up again, and we'll see this again with the renal respiratory stuff. There will be some practice problems that will be on your blackboard that will say arterial blood gas practice things, and that's something that's going to come up quite a bit, even in nursing school, and that will get you pretty far ahead if you do those arterial blood gas things before you. Hopefully, we're getting you prepared for that.
My biggest concern with everything going online is my understanding of everything that I'm learning. I'm scared that I'm missing something and that, if I do get accepted into nursing school and go, that I'll be like missing something huge. But my mom, she's a nurse and she keeps reiterating that they go over everything. They don't just blindly hope that you were able to absorb every ounce of information.
Right.
So
They're not just going to throw you out there and say, don't kill somebody.
yeah.
So there is some of that. Now, there's some of it, they do expect you to have that foundation, like the pathway of blood through the heart, that sort of thing. It's nice to have that foundation there. And so that's really, now that we've gone to this online format, that's really what, at least I've been trying to stress, is those big picture concepts that I know will come up later. And hopefully that's what's reflected in the course so far. All right. Well, if you guys come up with any questions between now and whenever, tomorrow, I suppose, drop me an email and I'll answer any questions you've got. I'll get your exam uploaded. It'll come online at midnight, and you'll be able to start both of those and work from there. But like I said, if you have any questions about it or any questions about the questions on your exam or anything, just drop me an email.
All right. Thank you.
No problem. You guys have a good night.
You too.